Hello and welcome back to On the Edge, Conversations in Emerging Medical Technologies. I'm Dr. Jonas Moses, and today we are talking about optical coherence tomography and its uses in ophthalmology, especially in the treatment of retinal disorders. With me today, Dr. Jennifer Lim and Dr. Jennifer I. Lim. And Jenny, right before the break, we were going to move to a next slide where you talk about AMD, and it's a treatment slide, as you said. Can we bring that slide up? There you go.
And you see on this slide an example of a patient with macular degeneration that had been treated with something known as Macugen or pegaptinib and still had those areas of elevation, those areas where the orange line goes up, so there's a pigment epithelial detachment, areas above that that are dark, so that's subretinal fluid. And a normal retina, as you remember from that first slide, doesn't look like that. So now this patient was treated with a new anti-VEGF drug known as Avastin, one of the ones that we have available to us, another one being ranibizumab, which is the FDA-approved drug. And all of a sudden you see that the retina has collapsed and flattened. So that's pretty remarkable. We can say, okay, we've gone from a central subfield thickness of 243 down to a thickness of 203, which is almost normal. And the difference, I say almost normal, and the difference is that you can still see some areas of black underneath that orange line. So there's still a little bit
of fluid left there, right?
Right.
And you mentioned a drug, and there actually is a controversy, a little sidebar here. A little controversy, actually a fairly great controversy. We are, after all, on a program where we're talking about emerging medical technologies, and in past programs, I've discussed some of the issues of the availability of a technology or of a medication not making it to the marketplace because it was there was something blocking that, whether it was the FDA or patent issues or a race to the marketplace or not being able to exactly appreciate the innovation in an invention and other impairments to the process of getting the treatment to the end user, the patient. In this particular instance, there are two medications we're talking about here. You mentioned Avastin. Avastin has been used in the past as an anti-angiogenesis drug in the treatment of cancer. The thesis having been that tumors create their own blood supply. They create a neovascularization. That's a separate show, and I've talked about that in the past. However, in the retina, when we see in diabetic retinopathy and some other diseases, these neovascularizations, this is tiny new vascularities, tiny capillaries that are very fragile and leaky, and you want to slow or stop that process because that gets into the visual field and gets in the way of vision. And so Avastin was, is a kind of a logical thing to use. And then the manufacturer of Avastin came out with something specific to ophthalmological use, and that is
ranibizumab. Let me give you a little bit of history around that.
Please do.
What actually happened was Genentech, through the use of researchers such as Napoleon Ferrero, who helped identify VEGF, et cetera, realized
VEGF is
vascular endothelial growth factor, which is put out by the eye, and it causes new blood vessels to form. And so what Genentech said was, well, if there's an increased amount of VEGF in eyes with macular degeneration of the wet form, the neovascular, then perhaps if we attack that VEGF and prevent it from binding where it needs to, then we can prevent the new blood vessels from growing. So this started over 10 years ago, and Genentech put in resources to develop anti-VEGF type drugs. So they created an antibody to it. And specifically for the eye, they formulated this to be small, so you could inject it into the eye. It would get through the layers of the retina to where it needs to get.
It's a small molecule.
And work. Right. It's very tiny, 78 kilodaltons, right? Versus 148 for Avastin. Right. Ballpark. And so they didn't think that Avastin would get all the way through. So now keep in mind that ranibizumab was specifically developed for this. It went through clinical trials, which I took part in. The Anchor, the Marina trials, the PIER trials, these are all names for macular degeneration trials. And it was proven highly effective. 97% of the time, after 2 years, the patient did not lose up to 3 lines of vision. In other words, they maintained their vision. And in fact, for the very first time, patients were actually able to gain vision. 35 to 40% gained 3 or more lines, which is unheard of for age-related macular degeneration.
Good. Okay.
Unheard of. I mean, you think back to the early 1990s when all we were doing back then was studying laser photocoagulation, in other words, burning out that retina. And we would tell the patient, look, your vision will be better 18 months from now than it otherwise would without this treatment. And yet you were putting a black spot in the center of their vision. And now, you know, in 2007, we're able to improve their vision 35% of the time, 3 or more lines. That's pretty amazing.
It is amazing.
It is amazing. So, mind you, it takes a long time to develop that drug for the eye, run the clinical trials, and get it FDA approved. So, in the midst of this, when we realized that, yes, it's working, but we couldn't yet give this drug to patients, other physicians, one of my friends, Phil Rosenfeld at Bascom Palmer, said, well, you know, why not try Avastin?
It's already out there.
It's already out there. It's approved for use for colon cancer. We can get it. And they decided on a patient who was willing to just inject it in the eye. And lo and behold, it worked. Again, no safety done on it. No clinical trials were done. But it caught on like wildfire because around the country, retinal physicians said, look, I can actually give this to my patient. And they were
save
seeing
vision. Sure.
and save vision, and they were seeing positive results. The problem with that is it is not FDA approved, one. And secondly, it wasn't formulated specifically for the eye. And there was some controversy you alluded to in October, perhaps.
Yes.
Yes. And the problem was that inspections by the Food and Drug Administration, I believe, are looking at these compounding pharmacies, and they're saying, well, maybe the components aren't as pure as they need to be for an injection into the eye. But that's all since been resolved, and things are moving forward, and we are able to still give Avastin to patients. Again, it's off-label. Now you might say, well, if there's an FDA-approved drug, such as Lucentis, and it's covered by insurance, why are doctors using Avastin?
Well, let me interject there and say that part of the controversy was that Lucentis is incredibly expensive, $1,500 to $2,000 per injection, whereas Avastin is $100 to $200 per injection. And for people who don't have insurance, they're out of luck. If they have to go to a physician who tells them, sorry, it's not covered by your insurance.
That's part of it, yes. And so it's partly an economic reason for doing that. Now, that being said, there are indigent programs where patients without insurance can apply and get the drug for free. It does take a little bit of time, but I've actually used it. You can do that. I think another pressing issue is when you're using it in off-label applications for patients who have swelling or abnormal blood vessels, not from macular degeneration. Say someone's very nearsighted and they have an abnormal blood vessel, and maybe their insurance won't cover Lucentis, then you can try Avastin on them. But, you know, it's controversial right now, and there is a study known as the CATT that is going to look into that.
CAT study is
Exactly.
47 clinical sites throughout the United States, by the way. And it's going to follow patients for 2 years, I believe.
Right.
So.
And it's sponsored by the National Eye Institute. And they will go head-to-head, Avastin or bevacizumab, which is the generic, and Lucentis, known as ranibizumab, generically, from Genentech, which makes both drugs. It's a really unusual situation.
Well, and it's a situation, and this is, you know, I've spoken about in past shows, an issue when one company has developed 2 different innovations that compete with one another. They're less likely to put the second one on the market. We are going to a commercial break. We'll be right back. Stay with us. You're watching On the Edge, Conversations in Emerging Medical Technologies. I'm Dr. Jonas Moses.